Thank you, Dr. Cha. I could not have done a better job as to why this talk is so important. And it's actually a talk I really enjoy giving because I think some of you may know I was deeply involved with the design of the vision trial and treated many patients in the vision trial. And specifically regards to patient selection, I played a large role. So again, my disclosures. And in case you guys weren't here for the first talk, we care about the vision trial because it was the key trial to get approval, and it showed us that we can improve overall survival in this very difficult to treat patient population. All right, so let's talk again about the two molecules that we use in the vision trial, PSMA 617 and PSMA 11. And we can delve into the chemistry a little bit more here. And, you know, David talked about this a little bit, how we take it for granted in a lot of ways that we get these molecules perfectly delivered and they're stable and everything works perfectly, and so much work goes into that. But the gallium molecule, when you Adam, when you put into gallium PSMA 11, this is a linear chelator, and actually you could just do this at room temperature, all right? Because a lot of people have asked me, why did they not use this for PSMA 617 as an imaging agent? You actually could have, but gallium PSMA 617 is not really being explored as an imaging agent as far as I know anywhere. But this molecule, I do want to point out, this PSMA 617, that's what we call macrocyclic chelator. When you put a metal in there, you actually have to almost boil it, okay, to relax that ring structure. And then you mix in the metal, and then when it cools down, it locks it in. So the molecule is very stable and will hold on to that metal for days and days and days. That's very important when you have a beta particle or alpha particle emitting isotope, because you do not want that to release over the days. Now, gallium PSMA 11, you image an hour after you inject. If it falls apart, you know, a day later, you will never care because you've already done your imaging. So they are different molecules, but again, very close biodistribution of these and tumor uptake because of the similar binding moiety, and there wasn't any major changes in the lipophilicity. Although the gallium PSMA 617 does, if you were to image the PSMA for longer, has better tumor retention. Now, the design of these PSMA PET selection criteria, as I alluded to in the first talk, the PSMA PET selection criteria used in the vision trial went directly, word for word, essentially, into the prescribing information by the FDA. Okay, so I'm going to give you the firsthand information on how this was designed, since I designed the PSMA PET selection criteria. And if you're making any read criteria, which is kind of what I do in my job these days, it's actually very hard. Okay, you have to find a balance. Patients are very complicated. Okay, especially ones who have had multiple lines of therapy and everything. So you need to have a rule set that sort of respects the complexity of the patients, but it can't be too complex or else you won't be able to reproducibly do it, okay? And you also, in real life and in the trial, have to accommodate for varied image quality because you have multiple sites. They can have scanners of very different ages, for example, and reader experience. When we did the vision trial, there was no PSMA PET tracer approved in the US. And the majority of the readers we had for the vision trial had never read a PSMA PET scan before in their lives. So I had to train them first how to read a PSMA PET scan and then how to apply the rules. So now, fortunately, it's very different because PSMA PET is widely done in the US. And the other thing you want to do when you're trying to decide read criteria is if you can relate these novel read criteria that you're creating to something that is familiar, it will really help you to make it more easier to apply and easier to remember. And then once you've made your first draft of your read criteria, it's good to get a variety of input and perspectives from all sorts of folks. So this is the flow chart that I created to hopefully explain this very clearly. This has already been published, so you can look this up in the Journal of Nuclear Medicine. First of all, many of you may have heard about using FDG and PSMA PET. Okay, very widely used that way in Europe as well as Australia. The first thing I did was to decide we are not going to do FDG PET at all. Right? Why? Well, there's many, 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 many reasons actually, and I had to fight forever because when everyone's coming after me to, well, you got to put in FDG PET. I was like, no. All right. So there's many reasons, but having two PET scans to look at and then compare actually makes this much more complex and would reduce the reproducibility of this. Second, we knew with high probability that whatever we did in the trial was going to be how it was approved by the FDA. And getting an FDG PET approved by insurance for selecting patients for radioligand therapy has never been done. So we were really concerned how that would delay getting this used in real life when it got approved, hopefully. And as you said, the VISION trial was successful, thankfully. So there's no FDG PET required in this whatsoever. All right. So the first thing you do is you look at your PSMA PET scan. All right. And you either use a coronal images or a MIP. And what you want to do is check to make sure there is at least one PSMA positive lesion somewhere in this patient. Now, PSMA positive, we defined here like it had never been defined before for the purposes of a late stage clinical trial. In initial staging, biorecurrence, PSMA PET for diagnostic purposes, you say it's PSMA positive, you mean it's prostate cancer. For this criteria, PSMA PET positive means that it's greater than liver by visual assessment. And what does that mean? It means this tumor or metastatic deposit has enough PSMA expression that if we then treat it with 200 millicuries of lutetium PSMA 617, we believe we will give enough gray to that tumor to make it respond. Okay? So we actually define PSMA positive in a different way, different from diagnostic utilization, but instead for theranostic purpose. Okay? Greater than liver visual. Greater than liver visually is something we're very familiar with in nuclear medicine, right? For the Lugano criteria, Lugano and the Deauville criteria. In the Lugano, for FDG PET for lymphoma, we use the liver. So we have known we could do this reproducibly as a nuclear medicine community. For somatostatin receptor imaging, we have something called the Krennig score. We use the liver for that. We know we can do this reproducibly. So we related it back to that familiarity in nuclear medicine and use that liver as a threshold, greater than liver. And actually, if you look at the scans, only 5% of patients did not have a single PSMA PET positive lesion. So 95% of patients had at least one PSMA positive lesion. And you go on to the next step. This was the truly different part, okay? Since we did not have an FDG PET, we had to replace it with something. FDG PET is a very, very powerful tool, okay? You cannot completely replace FDG PET with any anatomical imaging, whether it's CT or MRI, but we can do pretty well. What is one of the most important things that FDG PET does for you when you're selecting a patient for metastatic castrate-resistant prostate cancer is to identify the most aggressive lesions. Aggressive lesions will have high PSMA uptake, high FDG uptake in general. And those are the most important lesions that you want to make sure have high PSMA uptake, right? But since we don't have a FDG PET scan to look for FDG uptake to identify our aggressive lesions, how are we going to do that by CT, all right? Well, in general, in any cross-section in time, the bigger the lesion, the more likely it's to be aggressive, okay? So one of the more interesting things that I have to explain is why do we only care about lymph nodes that are 2.5 centimeters in short axis or more, okay? If you have lymph nodes anywhere less than that size, you don't care what their PSMA status is. One of the nice things about this is that you don't have your readers looking at 30 lymph nodes that are 1.5 centimeters or anything like that, okay? It helps with your reproducibility because you're only caring about lymph nodes that are greater than 2.5 centimeters. So that really cuts down on the number of lymph nodes you have to assess. The original number in my first draft of this was actually 3 centimeters. Where did that come from? From the radium trials, okay, Radium-223 chloride. Radium is a calcium mimetic. It's a group 2 metal. It treats bone metastases by releasing alpha particles. And the metastatic castrate-resistant prostate cancer population in the Alsemco trial, they showed that you can improve overall survival in patients with up to 3-centimeter lymph nodes, treating them with radium, which only treats the bone metastases. So, what's that show? Survival is not really driven by nodal disease until it gets really big, probably. Okay. So originally it was 3 centimeters due to my borrowing that from the radium data. And then people said, well, that's pretty big. Maybe we should do 2 centimeters. And eventually it settled on 2.5. And I was like, that'll make a difference about 1 or 2% of patients whether I use 2.5 or 3 centimeters. So I wasn't going to argue with anyone. So that's where the 2.5 centimeters comes from. Has multiple advantages, but we wanted to include patients who had even 2 centimeter nodes are PSMA negative, particularly if they had a lot of PSMA positive bone disease elsewhere. We wanted to give them the chance of getting treated with lutetium PSMA 617. All right. Now, for solid organ parenchymal metastases, that's your liver metastases, your lung metastases, your adrenal metastases, as well as your bone metastases with a soft tissue component. Those are greater than 1 centimeter short axis. And for those of you who read a lot of RECIST 1.1 criteria involved with that, that is straight out of RECIST 1.1 for target lesion selection. Okay, so that is very familiar to a lot of imagers. Those are the RECIST 1.1 target lesion criteria. Okay, and it also allows us, again, not to worry about small lesions. Okay, and can you look at it and kind of compensate for partial volume effect, or somebody not missing a 3 millimeter lesion, another one was. So you're only worried about things that are 1 centimeter or larger. Notably, bone metastases. Not many bone metastases will have a soft tissue component of centimeter greater. Like only 1% of them will. So right away, you're not forcing your imagers to have to look at every single bone metastasis, which would be impossible. Some of these patients have hundreds of bone metastases. So you're only caring about those few that are really aggressive, that have that soft tissue component, just like David showed earlier, the fluid that have those lytic lesions. Those are really aggressive, and you want to make sure that those are PSMA positive. Okay? So if any of those lesions, any lesion that meets that size criteria, you need to now look at the PSMA PET and make sure it has uptake greater than liver or is PSMA PET positive. If it is the same as liver or less, even one lesion, they were excluded. In the VISION trial, 9% of patients were excluded based on that criteria. So overall, the exclusion rate by the PSMA PET criteria was about 15%. And due to some testing that I will never be allowed to publish probably, these were gauged to exclude between 10 and 20% of patients going into the VISION. And as you can see, we excluded 15%. So we accomplished that. If in any trial you are able to exclude 10 to 20% of your patients that will do the worst, your statistical power in your trial goes up by a lot. Okay, so that was our major goal. We did not want to exclude 50% of patients or higher, because this was sort of the last option for a lot of patients in this line of therapy. They already failed taxane, they already failed androgen receptor pathway inhibitors, and we had a lot of phase 2 academic data to show that this would be effective in the majority of patients, at least to some extent. Okay, again, out of my paper, this is an example, and I chose this example for a very important reason. Step 1, we have this MIP image. Do you have any lesion that's greater than liver? And as you can see by the nice blue arrow, you have this bone metastasis greater than liver. Okay, now you look on the CT. Does anything meet size criteria? Lymph nodes greater than 2.5 centimeter short axis, or parenchymal metastases greater than 1 centimeter. And on the diagnostic CT, which every patient had, which they already had to have for the prostate cancer working group, there is a liver metastasis there that's greater than 1 centimeter. So you need to look at that liver metastasis on the PSMA PET scan and see if it's greater than liver. Okay, you just have to take my word for it. I checked on the sagittal to make sure there was no respiratory motion, but you don't see anything greater than the liver. You only see liver activity. So this is PSMA negative. So this patient was excluded. I like this example because if you did not know by CT that there was a liver metastasis there was no way on that PSMA PET scan you were going to know that there was a PSMA negative liver metastasis there. So very important to look at the CT. Nuclear medicine physicians, I was one before I did radiology. I believe you can do this. You're not looking for tiny metastases, okay? Dave and I are radiologists too. I guarantee you, we miss tiny metastases all the time. We don't like to admit it, but we do, all right? These are not small metastases. You can look for these, and you might be looking at this more carefully than the radiologist did the first time. So you can really do this. Now, since these patients who were excluded didn't get treatment, and these PSMA PET criteria had never been used in any prospective trial, period, we actually didn't know how these excluded patients were going to do. But I knew that data sets would be retrospectively analyzed, and I want to thank the group out of UCLA for the first ones to publish this. So they retrospectively looked at their data set that they treated for many years and applied the vision criteria. And the blue line is if they would be eligible by the vision criteria or screen failed by, in red, by the vision criteria. As you can see that they had a separation by their PSA progression-free survival by using the vision criteria retrospectively on their patient population. So some validation that this rule set was effective. Now, an FDA mandated sub-study was, hey, these vision criteria by PSMA PET have never been used before. If we're going to prove this, people need to be able to do this in the real world. So we did an inter-reader agreement study as well as reproducibility study, as we do for many of our diagnostic studies as well. And this has already been published, but I'm going to show you some slides that we presented at EANM. We took 125 of these scans. If any one of you has to do these studies or design one of these things, these agreement statistics, they like it if things are 50-50 split. And as I showed you, it was like 85-15. So we actually had to enrich the cases for ones that were exclusion. So there were 75 initially read as inclusion and 50 as exclusion. So we enriched for it. And this is important because it's, as any nuclear medicine person will tell you, it's easier to see PET positive stuff than PET negative stuff, okay? So we actually enriched it in a way that actually made this a harder study to read than in real life. We did an intra-reader component, so we showed them some of the same scans over, but I won't go over that in the interest of time. We planned this to accomplish this like we typically did for these prior to COVID, where we would fly the readers in, I would train them, and they would read them on site. But then COVID happened, so we had to do all these, and I never used like a Zoom breakout conference meeting before. It all took a lot longer than it should have. And again, these 3 readers, they had never read a PSMA PET scan before in their life. I had to train them how to read PSMA PET and then how to read these criteria specifically. So these are the results overall. There was moderate to substantial overall inter-reader agreement. That was 3 out of 3 reader agreement in 77% of the cases. And those to break it down, 79% of those 3 out of 3 unanimous agreement were inclusion cases and 21% were exclusion cases. Why am I bothering telling that? As expected, agreement was less on the exclusion cases. It's harder to see PSMA negative stuff than PSMA positive stuff, okay? And I did a little bit of a further dive into why were these cases discordant, okay? And, was it all due to just one reason or just a couple reasons? But it turns out it was actually a whole variety of reasons that the cases were discordant. There was 6 cases where they disagreed on lymph node, 5 on bone metastases, 5 on liver, 5 on no positive lesion. So it's actually a whole spectrum of reasons. So it wasn't just one single reason that we could put our finger on to say, oh, we need to train people better at that. But overall, when I looked at why people probably had the greatest reason to be discordant was that they missed the CT finding, okay? And these readers had to read all these scans in just a short weekend. So they probably got a little bit tired as well. So try to do this when you're fresh. But you really, to catch those PSMA negative lesions, like I showed you with that liver example, if you don't see it on the CT, there's no way you're going to find it on the PSMA PET scan. This is an example of a PSMA negative bone metastasis that 2 readers appropriately called as PSMA negative, but 1 reader missed it, okay? As you can see, there's a soft tissue component here that's greater than a centimeter, and you look at the soft tissue component of that, and it is PSMA negative, okay? But the adjacent bony part of it is positive. So I suspect that one of the readers saw the positive part, but didn't really look specifically at the soft tissue, aggressive, lytic, destructive part and realized that was negative. So a tricky case, right? Here's another one, a lung nodule that was called PSMA negative by 2, but not by a third, okay? As you can see, here it is. And again, it was not misregistered. You'll just have to trust me. Very low PSMA uptake. That third reader may have thought, hey, this is maybe just one of those pleural-based nodules that's often benign. If I had a prior CT, maybe this was stable for 5 years, and I don't think this is a metastasis, and that's why I'm not going to call it. I don't really know why the third reader didn't call it, but you know, this is an example. I think if you had priors like you would in real life, people might agree about this one more. All right. The FDG PET issue continues to haunt me. I keep getting asked about this in every talk I give. So what I teamed up with many of you may recognize some of these names. These are some very, very brilliant German investigators at the Universitätsklinikum Essen, okay? And we actually accomplished 2 things with this, and it's why I wanted to show you this. I reread their data set applying the vision criteria, okay? One that they had used both FDG PET and PSMA PET, and we found this, okay? That if you use for PSMA 1007 something we call vision-like criteria, we get pretty good agreement between what they did with PSMA PET and FDG and the vision-only PSMA PET criteria, all right? But PSMA PET 1007 has this very high liver uptake. So if you only use the liver for that, you will exclude way too many patients. So the next best alternative is spleen. And actually you do pretty well if you use spleen as we did here, where only 3 out of 52 patients that were eligible by their criteria were called ineligible by the vision criteria. And ineligible, I think we called 15 ineligible and they called 20 ineligible. So no, it was the other way around. Sorry, we called 20. Theirs was a little bit about 30%, a little bit more restrictive than ours. Okay. And here's some examples. In the interest of time, I'm just going to zip through this really quickly. So this is your PSMA PET scan, okay? And this is PSMA PET negative, so you would have been excluded by the vision-only criteria. And very easy to see, though, by FDG PET that was super hot. So it was also discordant. And that's usually how it happens. The discordant lesions, they have low enough PSMA PET uptake, same or less than liver, that you would exclude them by the PSMA PET only criteria. I'm going to skip this one. And so we found that actually we do a pretty good job without the FDG PET, according to it. And if you're going to use PSMA 1007, you cannot use the liver. You wind up excluding way too many patients, as you'd expect. And this image from our paper, for example, here's another patient who also had a sacral metastasis, and it's less than the liver with PSMA 107, but greater than the spleen. So deemed ineligible if you use the liver, but eligible appropriately if you were to use the spleen as your reference region. All right. Another more interesting paper that's come out recently is out of this group, they compared the vision criteria with the therapy criteria, okay? Because there's different FDG PET, PSMA PET criteria. And therapy has SUV max as well as measurable sites of disease, SUV 10. And very interestingly, I'll jump to this, they found that the vision compared to the therapy, just like we found, allows for more patients to be treated. Okay, when you add FDG, you actually exclude more people. But in their data set, if you use vision, the hazard ratio is 3.1 versus if you use therapy, it was only 1.6. So you think you're actually doing better by excluding more people, but you may not be. This was a small number of patients, 30-some. So I think it's very interesting, though, that to explore this further. Okay. I'm running out of time very quickly, but I want to talk to you about the other FDA mandated sub-study. Okay, I designed this, executed this, and to my knowledge, nothing like this has ever been asked for by the FDA. And also, to my knowledge, the first time an artificial intelligence algorithm was ever used for an FDA mandated sub-study to gain approval. Okay, so we took all the baseline PSMA PET scans and we segmented the bone, lymph node, liver disease, and then we summed them all up into a whole body region. And we took the parameters SUV mean, SUV max, the tumor volume of the segmentation, and the tumor load. We used artificial intelligence algorithm to segment out all the bone metastases, or else I would still probably be hand segmenting them today. But then the soft tissue disease was segmented semi-automatically with a software program. And we compared each one of these parameters with the various outcomes. And this was presented at E&M. It will be published very soon. So you have this matrix of all these quantitative parameters with the outcomes. And the most important parameter that predicted outcome was whole body SUV mean, okay? You just lump up all the disease. You don't care if it's bone or lymph node. You just lump them all together. And all those voxels, the average SUV of all those voxels, okay? And for every 1 unit increase in whole body SUV mean, for example, going from 7 to 8 or 8 to 9, there was a 10% decrease in the risk of death, okay? We did a quartile analysis, all right? And we compared the standard of care arm with the treatment arm. And if you were in the bottom quartile, you still benefited, okay? Your median overall survival was increased by 3.2 months. But if you were in that top quartile, it was double, 6.4 months, okay? But even that bottom quartile still benefited. And again, these are patients that had already passed through the PSMA PET vision criteria, okay? So patients with large PSMA PET negative disease had already been excluded. Now let's look at this graph on the right. Instead of a quartile analysis, we go by every unit increase, okay, of whole body SUV mean on the x-axis, okay, greater than 7, 8, 9, 10, 11, 12. And on the y-axis, we have the hazard ratio for overall survival. And look at this quite linear correlation, right? As you go up in whole body SUV mean, when you give that 200 millicuries of lutetium PSMA 617, you're going to give more and more and more gray to those tumor. And look at the hazard ratio going down, okay? And as you get really high in the SUV mean, the hazard ratio is quite low. And this is what we'd see in about 10 to 20% of patients in many studies were the super responders, right? They do extremely well, okay? So there's some limitations, of course, mainly being this, this artificial intelligence algorithm used for the bone is not commercially available. And only one person hand fixed every single VOI as necessary, and that was me. So I'm not at every site. But hopefully this will be allowed, is a good step in allowing us to really tailor our consultations and predictive power. And another limitation is these SUV parameters are all done using gallium PSMA 11. Okay, the F18 values will not be the same. All right. And just really quickly, which I get asked a lot, which PSMA PET radar tracer can or should be used to select patients? As NCCN guidelines, SMI, EANM, and ASCO all say you can use the approved agents more or less. And this is the one from ASCO. All three of the FDA-approved PET agents here, it says, can be used to determine eligibility. But just want to note, I agree with that, but we want to be honest that the strength of the evidence here is still on the weak side. So this is my opinion. The VISION trial used gallium PSMA 11. So if it's possible to use gallium PSMA 11, you should use that, especially if you're going to try to derive something from the quantitative parameters. But multiple guidelines accept the use of all approved PSMA PET tracers. And if you don't have access to gallium 68 PSMA 11, I would not hesitate to use whatever you have on hand. However, almost all of them, the liver uptake continues to increase after 1 hour. So stick with 1 hour. As David mentioned, at some sites they use 90 minutes or 120 minutes. Your liver uptake continues to go up and up and up, and you'll wind up excluding too many patients, even if you use like PYL or PSMA 11. So thank you very much.